Well, thank you, Laura, for inviting me. I think it's an honor to be here and speak to you. I've met some of you throughout the last year or so through some of the meetings I've had with Laura, and so it's exciting to hear about everything that the different research that everybody's doing, and it was exciting to hear what Brad is doing in primary care too. So I think it was exciting. So today I'm happy to talk about a part of my research that's sort of near and dear to my heart, that I'm very passionate about. I asked Laura what she wanted me to talk about. I have my career development award in aging, and through Allison Moore, I was like, well, do you want me to talk about my aging research? And she said, talk about your health disparities research. And so I was like, okay. So with that said, today's focus will focus on work that I've done on Latino health disparities and then the social determinants of health, and sort of explain a little bit how my research has evolved from trying to understand that to then trying to evolve into interventions and doing, trying to change the way we practice medicine to sort of mitigate some of these disparities. And so briefly, my background, I'll talk about my background and goals, and then I have not too many slides because I know this group knows about the health disparities and sort of kind of where the USC School of Medicine has played a big role in counting USC and a lot of seminal studies in health disparities. So I won't talk a lot about background on health disparities, but I'll make a couple important points that I think are important to me that I think sort of get underplayed and maybe get a little bit more to the root cause of some of these health disparities. I'll talk about the heterogeneity of Latino populations, and then the access to primary care issue. It's an important one. And then the importance of diversity in research. And so I try to pick some areas that I thought were not just important for diversity, but also were germane to primary care and family medicine. I think things that sort of resonate nationally in family medicine. And so then I'll talk about some research projects that I've done on language access to care, and then on Latinos migration and diabetes. So I'll skip this briefly, but I think Laura mentioned some of my background. But I think the one thing I did want to add, that the reason this is near and dear to my heart is it's pretty much been the sort of the driving force in the research that I do, is trying to ground it based on my personal experiences of the patients that I see. I practice 1 day a week at Mid-Valley Comprehensive Health Center down in San Fernando. So it's a satellite primary care office of Olive View Medical Center, so part of LADHS. And so those are the patients that I see on a weekly basis. I do clinic once a week, and then I precept patients I precept residents half a day also. And so it's all grounded on sort of the clinical and my personal experiences. So overall, my goals of my research portfolio have, of course, have evolved over the last years at UCLA. But in essence, it's my driving force is really to try to improve the health and healthcare of Latinos and other vulnerable populations, and to conduct partnered research that influences health policy and education. Because I think as I began to do a lot of health services research, I was getting frustrated with sort of the part that focuses on understanding problems, and we all who do research sometimes struggle with the aspect of once you finish that research and publish that paper, then what happens, and sort of that big delay in knowledge to actually translating something into practice and the clinical setting. So a big part of my research is to try to conduct things in a partnered way, whether it's with a community health center or community organizations or senior centers, or a big or bigger health systems in general too now. And then I want to also enhance the way we think about physician workforce and pipeline issues. So I know that there's some medical educators in the room and do research on medical education. So I do some work with data from the AAMC, trying to look at the way not a whole lot has happened in primary care research over the last 10 years, and then primary care research, and then how sort of diversity. I think right now with sort of what's happening nationally with diversity, the different colleges and whatnot, it's sort of an exciting time to do this type of research, and I think this USC is and Los Angeles is a great place to do this, because actually in national meetings everybody looks to Los Angeles as sort of how are you guys dealing with diversity, and sort of how do you make the business case for it, etc. And then at the end is my goal is to be a change agent in family medicine. And so this is the one slide on health disparities, background slide that I have. And so this is the Institute of Medicine model. The way I think about it, I think I like this slide a lot because it covers some of the domains of research that I cover. So here we have in the first part, we have the non-minority patients, minority patients. It could be different characteristics, older, younger patients, patients with a certain chronic condition or without. And then the difference in the quality of care, that axis over there is the disparity. And so there's different things that are the root cause of the difference in the disparity. Some things we don't know about, we don't really understand much about. There's a lot of work being done right now on implicit biases and things like discrimination. I know that a lot of the scales that we have currently aren't good enough, because I've used some of them and I never find any positive results or anything with them, and never end up doing any intervention with them. But maybe some more things about implicit biases. Then there's healthcare systems and environment. So Brad was talking about healthcare systems and primary care. And so the way we do practice, the way we do open access to patients, and family medicine has sort of been a leader with that. And training in San Francisco, I sort of drank the primary care Kool-Aid in UCSF, family medicine there. And then the clinical appropriateness and need of patient preferences. So that's really important too, because not all, we have this medical, our health systems of over-treatment. Right, the older we get, we spend more money, we do more. And in parallel, sometimes patients that with language barriers we don't understand, so we also do more. And so some of those, these three things kind of encompass nicely some of the work that I've done. The other point that I'll make about on the background before I get into the research is that, again, not one size doesn't fit all. And I think being in Los Angeles, I think everybody here sort of understands that Latinos are a very, very heterogeneous group. But nationally, it's still not a well understood concept. And so this is a slide that I just like to put up because it's a busy slide. So I apologize for that, but it's a slide of the HSOL study, and I think the coordinating center is in San Diego. And so it's one of the biggest Latino cardiovascular studies going on right now, and it has different Latino subgroups on the columns right here. And so you see that they're not, all groups aren't the same. For example, Dominicans have lower smoking rates than Puerto Ricans, really high, 34%. For example, diabetes, Mexicans have 19%, rather than South Americans 10%. And for women, similarly. So those are just some of the common conditions and health behaviors that I pointed out. But it's a very heterogeneous group. But even on this basic measure, there's so much variation. A comparison group right now is the Asian subpopulations. Sometimes we do the Pacific Islander Asians, and they're very different. In LA, especially in Long Beach, we have Cambodian community, Vietnamese community. I mean, it's a wide range of communities. And I think being in Los Angeles, I see that as an incredible opportunity for research, because a lot of other places in the country are really jealous of sort of the opportunity that we have to improve health here. And so the other point I'll make on the background for primary care is that there's just a misdistribution of physicians in California, and that as we think about the access to care issue and Obamacare and uninsured rates kind of dropping, we don't know where that's going to be headed. But there's still a misdistribution. Some areas are sort of being left behind, the San Joaquin Valley, the Inland Empire. And so it's sort of the centers of primary care here in Los Angeles. I think we also have a responsibility to, an ethical responsibility to try to address some of those issues. And it's a unique opportunity for family medicine to fit right in, because I'm sorry if there's any specialists in the room, but pediatricians aren't going to go, there. I mean, I think the, family medicine, the tradition in sort of the footprint in the Midwest is that family medicine does a lot of the rural care. And so this is just a map of the health professional shortage areas. And so there's still, it's just a visual of the prior slide, but a lot of counties in the Central Valley and the Inland Empire. So a lot of opportunity to do primary care research as it relates to family medicine. And the reason I put this slide, so I just completed a systematic literature review of predictors of primary care practice in underserved area for the paper that's in revision in academic medicine. And so we know a lot. There's a lot of literature about predictors of practice in underserved areas, and family medicine has been a big leader in this research. And so I circle here, and apologize for the small font, but the studies fell into 5 different buckets and categories. So one is personal characteristics or intrinsic characteristics. Things that are intrinsic to a person, their race, ethnicity, where they grew up, where they rural, they grew up in inner city, etc. That literature is very strong. 19 studies that showed positive associations, and then there's the financial factors that I think those need to be redone with Obamacare and sort of the changing of our healthcare system. So that's pretty much a wide open area of research that I think we need to tackle next. And then there's the medical school programs for underserved urban, like Drew and the Jefferson program in Pennsylvania, and the medical school programs for rural areas. And then there's the residency training, which is the big component, almost exclusively all family medicine research. And I think that with the new Institute of Medicine reporting family medicine and GME training, I think it's wide open. I think it's going to be an opportunity for family medicine to do more innovative residency trainings, linking them to community sites away from the hospitals. But these are true and tried programs, and I think where the policy is going to go is with at least that we hope it goes is to try to replicate some of the programs instead of reinventing the wheel, because there's a lot of great models in the Midwest and in other parts of the country. And so then the last thing about in the background is diversity in research. So it's not just about it's not about the business case or the sort of the ethical, the right thing to do, but it's also improves research. So this is a slide that I really like about Dr. Bouchard at UCSF, who does research in asthma, and so he did genetic variants of patients with asthma, and as we know, Puerto Ricans always say, well, they have hard to control asthma, they're non-compliant, and so that was a story that he was trying to determine. Is like, well, why do they have bad uncontrolled asthma? And so it turns out that in this paper that he found evidence of associations of genetic variants within patients, the different subgroups here, and then the response of their medication to their asthma. So we don't understand it, and sometimes we don't understand it because the research that is done doesn't include a lot of diversity, and so I think that is a big driver for me to do health services research and health disparities research. The last thing is instruments across cultures. So we measure something, but if it's biased result, what does it mean? Probably not a whole lot. Instruments that are not validated for particular groups may carry different psychometric properties. So they could be culturally, educationally biased. And the example that I like, there's the mini mental static. There's like 8 versions, or probably more different versions in Spanish with different wordings, translations, etc. And so which one do we use? Is it the same thing? So these are all opportunities that I see that I hope to capitalize in the future. So the Yale Physical Activity Survey that I've used in the study, one of the recreational activities scale here, one of them is golfing. If you go ask somebody in, down in by LA County, USC, if they've gone golfing, how much time do you spend golfing? You're going to get a lot of zeros there probably. So I think that these are all areas that are really important to my research and opportunities for primary care physicians. And so I'll briefly mention this. And I think everybody here is sort of aware of the framework of determinants of population health. And so instead of the healthcare behaviors, the medical care slides, I think Mitch Keck from LA DHS says that in his model in LA County, maybe 20% of a person's health is accounted to the medical care. So, you know, there's a lot more that everybody here works towards, and that's sort of why I love working with communities. So now I'll mention a little bit about some of the research that I've done in improving language access. And so this is how we've all felt this when we travel, etc. And unfortunately, our patients in Los Angeles feel this when they walk in, you know, the doctor's office or the hospital. So one of the studies that I did was leading one of the evaluations for the RWJ Hablamos Juntos national demonstration project. So this was a $10 million project that RWJ funded to implement language access programs in 10 communities that had rapidly growing Spanish-speaking populations. So LA wasn't included in it. It was in places like Tennessee, places like Alabama, I think was one, Arkansas was another one. So places that have rapid growth, and obviously the purpose was to try to help the communities provide better care to their growing diverse populations. So it was a lot of interviews, and now it was analysis of 1,500 Spanish-speaking Latinos from the 8 outpatient sites in the different states, and the response rates range from 45 to 85%. And so one of the analysis that we did was looking at unadjusted sort of receipt of medication information. I think we all know that those patients were pretty bad at communicating when we prescribe, and we're pretty bad. And we're definitely, you know, we might say the name or the how many days, but I mean, it takes a lot of discipline to go down the list of listing the purpose of the medication, the side effects, the directions, and then also the written components are over here, whether they receive written components in Spanish, where the label on the medicine was in Spanish, in this case because it was Hablamos Juntos. And so in this analysis here, we looked at, you know, how often patients receive these patient reports of receipt of medication information from their doctors. And so here on this axis is the percent of responders, and here are the pieces of information, whether either oral or given. And as you see, the blue bars represent the patients that used an interpreter, and the gray bar represent patients that did not use an interpreter. As you can see, overwhelmingly the proportion of patients that gave better reports of care were the ones that used an interpreter. And so this was in a best case scenario in states where the population was growing, so there isn't a lot of bilingual staff in the hospitals. They were selected based on criteria because they didn't have interpreter services in their hospitals, and etc. And so then we also looked at domains of provider communication by interpreter use, and we used a composite of in the survey about 4 items, and we made a composite score from 0 to 100. So in this axis is a communication score, and down here it's 3 categories: whether the patient did not need an interpreter, whether they needed an interpreter and always got one, and whether they needed an interpreter and not always got one. And as we see, those that always got an interpreter gave better reports of of provider communication. And so some of the domains in that composite were questions that are very similar to the HCAP surveys, ambulatory HCAP surveys about friendliness and the office friendliness and things like that. It was a battery that was adapted from the HCAPs. And so in doing a lot of those, the data analysis of the Hablamos Juntos, you know, it was always like, well, so what? So the evidence mounted, and you know, clearly language is important. So some of the other things, the projects that I've done around language access is implementation of language assessments for staff in community health centers. So this is a publication of a project that I did with community health centers, and where they were interested in using their assets, their bilingual staff here in California. And so, you know, they don't have the resources to give professional interpreters, which is the gold standard, but realistically it's not going to happen for smaller community health centers and a typical community provider out there. So this is an exciting part of research, is when I get to go and evaluate somebody with a community that actually has a project and they're actually changing the way healthcare is delivered and the culture of medicine, and and impacting patient health and healthcare. The last thing about the language disparities is this is a bar graph out of a paper that I published recently with some colleagues from University of Washington and Group Health. It's on group health cooperative data patients from group health, and asking them about whether they had access, whether they had used the internet portal to refill their medications for diabetes and hypertension. And so I think the point of showing this one is that the healthcare system is changing a lot right now, and I think we got to make sure that we kind of lift all boats and we don't exacerbate disparities. And I make that jump to exacerbating disparities because group health within that same population, they've done studies that those patients that use the portal have better A1C control, are more likely to be on a statin medication, and so better outcomes. So at least there's a lot of emerging evidence from group health that using the portal might for certain group of patients is going to improve their health. And so here we see in the percent of patients here that use the internet portal or the telephone, as a matter of fact, to refill their medications. And then their English proficiency. LEP is limited English proficiency and EP is English proficient. And we see that 83% of the English proficient patients use either the internet or telephone to refill their medications, and only 46% of the limited English proficient. And so this is a heterogeneous group from Group Health, so it's Spanish speakers, Korean, Vietnamese, and then the Chinese dialects too. A study that we did it in 6 languages, and so it took us about a year to do a lot of the translations for the different languages, and so we ended up using different vendors to do the different languages. We found out, so that's kind of another talk, is the pearls of doing like research, multicultural research, is that even if you want to get a vendor out there to do the surveys for 6 languages, you're not going to find one. We found out we thought we had one, and it was it was really bad either in the Korean or the Spanish, or they didn't have the Vietnamese, and so it was quite challenging to do that, but it was important, like you point out. And so then, for Latino health, and for another focus of my research portfolio is diabetes and chronic disease. And part of the reason that this is important to me is that I personally grew up in the San Joaquin Valley in Merced, and my grandparents were farm workers. And so my grandfather came to the U.S. as a bracero in the 60s as part of the World War II immigration program. And so it's near and dear to my heart as far as sort of the social inequities of that population. And I mean, and for good reason that California has the most agricultural workers. I mean, this is the main breadbasket of the U.S. And so this is an analysis that I'm currently working on of a national survey of agricultural workers. It's a national database. I took the California out for this slide here, but this kind of shows you characteristics of these patients here. Well, not actually these people here, these persons. And so they're obviously very young, mostly male, kind of what we expected. Low education, majority married, born outside. Migrant, Spanish, so insurance coverage, that's before Obamacare, and then Medicaid, not too many on Medicaid, fields, etc. And so this is the interesting part of here. So the community health centers, not too many out there, 29%, the majority of them get their care from private physicians, which is actually just like the majority of Americans, we don't get our care from community health centers, we get our care from the small private, the commercial physicians there. So this is the asking, when they ask the farm workers where their last source of care was. And so very few, the ER, right, wells here, ERs overused by undocumented immigrant workers. Very few use it. Of course, these are healthy patients. I mean, I should say younger patients. And then, the healer, I was here about in curanderos. When I went to UCLA first year, we had a big orientation on cultural competency. They got this guy out who's a curandero, a healer, and we spent like a half day and talking about the healers in Los Angeles, and not too many people use them. I mean they're out there, and it's important to understand, and because it's a lot of variation, but kind of in the big scope of healthcare and health disparities, it's probably not the biggest issue to focus. You got all the whole medical school class in the room for that. So one project that I recently finished is improving diabetes care in the Central Valley, and so this was a community partnered project with a large community health center that serves about 2 counties. So they're basically the safety net for 2 large counties in Central California, and so it was on a registry of about 5,000 Latinos with diabetes. So we did random samples of surveys with medical chart abstractions, had hired people from the community to do the abstractions, were part of the study, remotely supervised them, did a lot of driving out there. And so this was sort of like a typical health services project, data collection. We went, we had the surveys, we abstracted quality of care measures from their medical chart, receipt of processes of care, then we did intermediate processes of care. So processes of care, like whether they got their flu shot, whether they got their A1C once a year, they got their LDL in the last 12 months, etc. And then the intermediate risk factors, whether they had their blood pressure under control, their A1C. So we didn't just focus on A1C. A1C is, as clinicians, we give it probably too much attention. We focused a lot on blood pressure. When you kind of take consider the horizon to benefit from treating somebody for glycemia versus blood pressure, you're going to get much more bang from your buck and save a lot more people from strokes and heart attacks from focusing on the blood pressure. We measured interpersonal care ratings. We used Anita Stewart's scale from UCSF, multi-item scale of interpersonal care ratings. So again, it's sort of germane to family medicine, is patient-centered care. And then the social determinants of health that I'll mention. So this is the valley. At the time when I did it, the recession had just hit, so there was a lot of poverty going on, and it was a bad time to do the research because there were the highest rates of food insecurity in the state. And so food insecurity, why is it important? There's a lot of NHANES data that shows the associations between food insecurity and obesity, developing diabetes, and elevated lipids and cholesterol. But what hadn't been known at this time is really the link, what happens to those patients that already have diabetes? Well, how does the food insecurity? We spend a lot of time, I don't know how many minutes and hours in the exam room telling people about their diet and exercise, but at the end of the day, if they're not going to be able to access the appropriate foods, we're kind of going on this hamster wheel as in this circular treatment. And so this is a model that was published in the New England Journal of Medicine on food insecurity and diabetes and chronic disease. And so it constrains the patient's options for food, and it leads to compensatory diet. Then people develop obesity, hypertension, or diabetes. Then they have their competing demands for health services. So the idea is, they got a lot of medications. They got to take off work to get their eye exam. Then the next day they got to take off work to get foot exams. They got to go see the specialist, the nutritionist, and so there's a lot of competing demands. So that leads to poor control of risk factors, and then increased health costs and competing demands. And for this population, it was sort of difficult because it was confounded by the fact that the seasonal variation of their jobs. So during the season, there's enough for food, but so try to save up, and then the off season is they go. There's all this they try to compensate by getting these cheap food that's available to feed themselves and their family. And so this is where I was interested in, is what happens when somebody has diabetes. How do they deal with this food insecurity? What does it mean? And so the main results for that particular study was that in the rural Latinos, I made a composite measure of control of A1C blood pressure and LDL cholesterol, and we see that you know, those that had food insecurity were less likely to meet that composite measure. And then there was also some findings for the receipt of process of care, which that one I kind of expected it because, you know, there's a lot of appointments, a lot of you know, trade-offs they got to go in, etc. But those with food insecurity were less likely to get a dilated eye exam, an annual foot exam, and then or to receive all processes of care. And the one that the big hypothesis going in was about the medications, because that's a big, you know, out-of-pocket cost. Is that those that had food insecurity were more likely to report cost-related medication underuse for the diabetes drugs. So these were adjusted odds ratios. And for the same study, we looked at the interpersonal care. So the domains are on the bottom: clarity of communication, eliciting concerns, explained results, respectful and compassionate, and decision making. And so the gray bar is Spanish language concordance, and then the gray and the dark gray, and then the light gray is discordant languages, meaning with their physicians, because it's out in California, so there is a lot of physicians, not a lot, but there's some physicians that speak Spanish, and so it was a nice opportunity to look at language concordance without the interpreter part there, because the interpreter part, like you were saying, whether it's professional or not, it can be like a gray box there, you know, don't know exactly what's going on. And so we see that those that had language concordance had higher reports of interpersonal care across all the domains. And the last thing and this particular study was that I was interested in was sort of the neighborhood, the rurality in California. And so here, you know, it was postulated that, you know, neighborhood effects did impact their perceived neighborhood problems, so what actually is in the neighborhood and then what the patient perceives it. Because potentially, you know, the patient may not perceive, for example, crime to be a problem if, you know, it's been argued that if the patient lives in that environment, it's not a problem. So there's always this debate whether to measure it objectively, like actual crime rates and litter, or versus a patient perception. You know, the patient perception is what the patient feels is, and so, you know, people are going to, perception, it kind of depends what you know, kind of value as being more important, but we opted to go with perceived neighborhood problems as opposed to census tract type measures. And so the hypothesis is that, you know, those who had a lot of problems are going to have, we're going to have associations with worse control of their intermediate risk factors and their perceived self-reports or quality of life reports. And so here, these are the main results for this analysis. Is the neighborhood perception. It was adjusted odds ratio, and so this row here is perceived neighborhood problems. Here is whether they had one or more problems, and then on the bottom whether they had no problems in their neighborhood. And so the data was pretty skewed, so we ended up cutting it at one or more problems because most people, you know, about half of them had no problems. And so here we see that, you know, there was a significant association with BMI and then with blood pressure again, but not with A1C or LDL cholesterol. And so I think, you know, other interest of mine in research is, you know, increasing participation in older minorities in research studies, and then the medical education, and then primary care and health systems innovation. So lately I've done a lot with clinical pharmacists and interdisciplinary team-based care in 28 practices at UCLA, and lead the evaluation for that. So we're looking at things like provider satisfaction, utilization, and transitions of care, sort of like global health system things. But in summary, you know, improving health disparities is hard and obviously multifactorial. But I think, you know, one of the main things that drives me is focusing on things that really do matter. You know, that are root at basically the root of the problem is social determinants of health, and things like food insecurity. And so one thing is place matters, that it's not about medicalizing everything. I think as we think of older adults, that's kind of where things are going now, is, we over-medicalize our older adults in the U.S. And then for the research that I presented on agricultural workers, that they support a big industry, but, they're often left out, I think, because my personal opinion is the political centers of the state, either in LA or San Francisco, and so there's not a lot of pull there. But in the future, I look forward to more interventions and policy research as I try to move more from descriptive to intervention and health system-based studies. Thank you.